All right. All right, great. And if there were anybody else joining on the public side, Dan, you would be seeing them now and letting them. Okay, great. Hello, Lisa Letourneau with DHHS, here with Dan Matz from Governor's Office for Policy Innovation in the Future for the third and what's currently scheduled as the last work group meeting around healthcare, AI in healthcare under the Governor Task Force for AI. So I had sent around a proposed agenda that also included some sort of summary to date um, reflections of what we've talked about previously in this group. So it's sort of embedded in italics in the agenda. And the key point really was to try to get feedback on that, what we've captured so far, and then additional discussion of the 5 key questions kind of grouped into 3 key questions as our task for the work group. So hello, Dan Cataract. We are a small but eager group here this afternoon. We're just getting started. Dan, I put down for you to maybe just remind us of our charge here.
I would be happy to do that. I might, in the interest of knowing that Chris is only with us for the first chunk and that he's heard me say this now uncounted number of times, I might maybe push that a little bit towards the end of reviewing the charge, if that makes sense to everybody, and we'll just help try to leverage Chris's mind here for some of the substance before he leaves us for his double booking. If that makes sense.
So I'm sorry, you're saying
I think maybe we'll skip this for the moment just because Chris has to leave us early.
Right.
So we'll just jump into the substance.
Okay. So I just noted that on the agenda, so Dan had capably captured some of our discussions to date under those 3 key questions. Actually, I put there's italics under the beginning of the 1250 section, but under the guiding questions, Q1. So, are there areas where AI offers promise for Maine's healthcare challenges and barriers to adoption? And so had captured that in much of our discussion. We really noted ambient documentation, remote patient monitoring, diagnostic assistance seem to be some of the primary things and ways that the states could potentially lower barriers. So thoughts about that? And why don't we just jump into that one and then just keep going from there? And obviously, this would get expanded in an ultimately in the report, in the governor's task force report. But the general ideas, folks have thoughts or responses. Hello, Mary. Thanks for joining on a Friday afternoon in July.
So very sorry to be late. I apologize.
That's okay. I'm impressed you're here at all. Chris only has the first 30 minutes, so we sort of jumped right into the agenda and under the 1250 section, the guiding questions. And I was saying we had summarized, actually Dan Matz had very capably summarized some of what we've heard to date in terms of the key questions. So we're just talking about Q1 and particularly trying to focus on, are there key areas within healthcare? We captured a few there, and other things the state could do in terms of addressing barriers. So there you go. Thank you. Lisa, so just opening it up for discussion. Yep.
Yeah, thanks. I think that certainly the bullets that are here under the Q1 on the agenda summarize some of the themes that we've talked about. One of the others that I know we've talked about in each of our meetings and in the broader meeting is just the opportunity around partnership for acceleration with private parties. I know that may be controversial, but it might be worth grabbing that. And then we talked in our last meeting, as I recall, pretty specifically about, a barrier for adoption being, just the distributed nature of what it's like to do healthcare in rural Maine. But I think turning that barrier and connecting it back to this other node around partnership. We talked a couple meetings ago about maybe looking at rural Maine demonstration sites, or I don't know what to call them, sort of experimental sites or innovation zones that could become showcases or showrooms for what's possible. And then the third thing I would just remind us of here with respect to the specific question in question 1 is our colleague from the Nurses Association who joined us was I think pretty emphatic about, not buying the hype and being a little bit careful as it relates to embracing AI as alternatives to people. And so a barrier may be, I don't want to say that people are the barrier, but we certainly aren't going to be successful if we don't take perspectives like that and work with them, and try to either address it point on through training and education, or find a way to kind of incorporate, in that particular example, the nurses more directly in the evaluation and the adoption or the experimentation.
Mhm.
I don't know that that would be enough necessarily for that particular group, but I think it's worth capturing that not everyone is really an AI believer or evangelist, especially in this setting. So there's work to be done around securing, both educating and aligning on common understanding about what we're even talking about, and then securing buy-in.
Mhm. Mhm. Yeah, very good points, Chris. Thank you. And I would also broaden that last point to AI literacy even more broadly. I mean, I think Sam and the woman from the nurses union were bringing a particular perspective and set of concerns, from a nursing staff perspective. But I think we've seen and read pretty widely that AI literacy writ large across provide other kinds of clinicians or providers, as well as patients and the public. And we just had a little bit of discussion about that at the wider AI work group last week, right? And talking about potential ways to do that. But I think that's even doubled or tripled in healthcare, right? That people are concerned about AI in general. And when you introduce AI into their own healthcare experience, that concern or fear grows exponentially in some.
Yeah. And we've learned a lot from this. And I totally agree. This is a huge aspect of what we need to make sure we're proactively covering, so that there's the state policy side, but there's also, roadblocks associated with people and or organizations that don't want to see it move forward. So we've got to proactively address those issues. And we've learned this with telehealth, with digital equity and inclusion efforts, like the people side of things. You can build it, doesn't mean they're going to come and use it, right? So I think, Chris, what you're talking about here is, ensuring that we identify those real and perceived barriers among different populations, whether it be providers, patients, nursing unions, and making sure that we have a way to proactively address them, so we don't get bogged down in people pushing back when they don't maybe understand what the benefits can be.
And maybe that has to do with what, again, the success criteria. If AI is successful, it does not, decrease the humans in the profession. It really enhances the ability for the humans to play their empathetic role, to really be front and facing with patients, really creates opportunity for the human necessary aspects of their jobs to be more fulfilling and more fulfilled, right? And I think that's critical to this, is everybody looks at it, oh, it's an easy way to get, to tame your workforce costs or whatever it is. Like, this is the immediate thing that people go to, but that's at the expense of the patient experience. I'm talking to a recording for 10 minutes before I ever get to a person. Everybody hates that, right? But if it's a way to get to a provider sooner, if it enables an opportunity to really speak to somebody who can truly understand their issues better, then it's a win. And I had a friend who was a nurse, and back when they started to install the Piximus machines and went sort of super uber computer friendly in hospitals, she says, look, poop doesn't come out of a computer. So like half of my job is stuff that the computer is never going to understand, right? And if it does, something went horribly wrong. But
Sometimes it does, but
sometimes it does, but it's not the same kind of poop. So, I mean, they're just, and I think nurses know best about that very often, very upfront and in your face human aspect of healthcare that, you just can't manage from that 60,000 foot view and imagine that you can automate, right?
yes, very good point. Um, Another thing I was going to add about ways to overcome that barrier of fear and lack of both understanding and trust is the need for transparency. Yeah, more transparency than what we're seeing now. Really, it's not. I know we've talked about it in a couple of the examples and the illustrations of AI, but in my own personal experience, at least, it is not transparent when AI is being used in healthcare. And if we're going to build trust, we have to start with transparency about it.
Yeah.
Other thoughts on this one?
I think just double clicking on, I said it already, but I'll just say it just a different way with a different sort of point of emphasis. And that is the realities in rural communities are just challenging. And so not only, kind of, as I said earlier, embracing this as a place of experimentation, but also maybe acceleration, right? There's the sort of famous Steve Jobs, comment about if you're sort of playing from behind, you can sort of work hard to catch up, or you can work hard to get ahead. And is AI an opportunity to really leapfrog some of these challenges, like as opposed to just try to get to parity for rural communities? Maybe there's a way that rural communities could be experiencing the best possible, personalized healthcare because we've really embraced technology, as opposed to trying to set the benchmark as, kind of consistent with what the way it might be delivered in a more urban setting. So I guess technology more broadly as an accelerant to, improve outcomes and service and care in rural communities.
Yeah, maybe getting to that same time, getting to that idea of appropriate and safe adaptability, because a lot of the models are built, and we talked about this, what was it, Dr. from Socopy talking about a lot of the models are developed in academic medical centers and rural areas, and we've got to be really careful to make sure that the models that we leverage for rural are appropriate and safe. Yeah.
Right.
Great. All right. Anything else on that one, or we can move to Q2?
Maybe just want to make sure the promise of addressing Maine's healthcare challenges. I think, again, it gets back to the rural area question. It gets back to the lack of an academic medical center issue, but it's maybe not just about the practice, AI in healthcare practices, but AI and continuing education and in the connection of physicians to physicians and all care providers to the latest and greatest findings that are out there. I mean, it is even it's a huge problem to keep people educated at the academic medical center level of new advances, because things are advancing too fast. 60,000 clinical trials in cancer right now. Distilling that information is like nearly impossible for people to learn from, even in the most education focused settings, but in rural communities that amplifies. And I think there have to be continued ways for AI to be able to quickly help physicians in rural communities identify the very best information and to validate it, or to create opportunities to contact specialists that could really help impact their practices.
Yep.
Yeah, that stuck with me too. And same, and don't know why I'm not remembering his name, but the doc from Socopy talked about how they used AI to do the audit on the diabetes panel, and what an amazing impact that had on the numbers that they were giving on the positive outcomes for those patients was really awesome. So it kind of, I think, ties into what you're saying there, Mary.
Now we see that in the cancer space with our MCGI programs as well. So I think it really helps to feel like, if you're in a rural community, to feel like you have the whole world behind you and the world's experts behind you, and leveling that playing field is just, I think, critical and possible. And I think that goes back to what Chris is saying about you know, getting ahead, not just getting even, but getting ahead, because how special to be to have access to the world's top docs in your cancer specialty, you know, even if you're in a tiny town and, you
Yeah.
know, the county, you know, it's
Yeah.
amazing.
And sharing those success stories in a meaning in an effective way, so that people who may be a little leery or haven't had access to AI can be like, hey, this
Mhm.
could be a really great use case for our organization to help impact patient access and outcomes.
Mhm.
I'll just jump in and just put a an example to this. And I think we heard this from the physician from Duke, who talked about the hub and spoke model that he's sort of out in the world trying to evangelize for. And I think it's exactly to Mary, to your point of geography is no longer the burden that it used to be. And if we can remove the geographic burden, then we can remove a lot of the other burdens of access and inequity that come along with it. And we can do so by leveraging the resources and know-how and of sort of urban medical centers in places that are historically would not be able to access them. So really interested in that model.
Yeah. Yeah.
Great. Well, in the interest of time, with Chris having just 10 more minutes, I'm going to open it up to questions 2 or 3. Chris, do you have, you can keep going in order, but I want to just make sure you have enough time if there's other things you want to add.
I'm sorry about that. You don't need to accelerate on my behalf, but
Well,
I
no, we
will
can
just
go back. I just want to
yeah.
give you time before you go.
I think you touched on the point I was going to make around question 2, and that was around transparency and informed consent or awareness. And I forget who just said it. It might have been Danielle, or it might have been you, Lisa. That educating the patient on how to like take full advantage of the technology is also, I think, a huge opportunity. Or maybe we could put it in the context of protections, right? And it may go hand in hand with transparency, right? If we're transparent and you're informed, you're also educated and prepared to participate and take full advantage of the technologies. And then the other thing I was thinking about with respect to question 2, again, thinking of our colleague from the Nurses Association, was really leaning into the idea that AI and technology is a complement to human-led care, and the quality assurance and sort of personalization and humanization that'll come through the clinicians themselves. I think that could be a macro theme that should frame it, all of this. Like, none of us are interested in AI as an alternative to human-led care. And so, but in this particular question, in the context of protection, there must be ways to sort of efficiently use people and clinicians to validate and assure quality as we implement technologies, and maybe make that, if we were to do something like we probably already have things like a patient bill of rights or things like that guide, our healthcare, paradigm in the state. Maybe something around, sort of the I don't want to say the humans are paramount. is what I'm searching for. I don't have the right words, but the technology or tools to enable the clinicians, not replace them, and to put them in the position to do the most good and the most effective way. And the net outcome is a better experience for all involved and better outcomes. Some motherhood and apple pie statement along those lines is what I'm suggesting in the context of protections. And then I'm just going to beat this drum all the way through October. I think we're missing an opportunity to not be like inviting every tech company in the world that has $1 to spend to Maine to help us, innovate and provide Maine context, whether it's healthcare or workforce or any of our other subgroups, as a design and experimental opportunity to accelerate tech innovation and put Maine on the map as the place to be doing business if you want to you want to figure out the next generation of your technology, we're open for business. I think, as I said the other day, we're seeing, literally multi-billion-dollar investments in other states, and we're not seeing that here.
So Chris, it's one thing I think to say that, it's another thing to identify the enablers that will really make it happen. And, I think we have to decide, what could be enticing about Maine that would steer folks to look at Maine differently than they have in the past.
That's a really good point. So on the enabler front, first of all, I think the recommendation might simply be the development of a team or a budget or a group within state government whose job it is to sort of secure new business and technological innovation investment for the state from among the private sectors and various industries. So then they can answer the secondary sort of question, which is, if we're talking about energy, what are the advantages? If we're talking about healthcare, what are the advantages? If we're talking about workforce, why would you want to do business in Maine? But I don't even know that we have the sort of the overarching paradigm of like, we're looking for new investment and new partners in these ways. And maybe we don't want to, right? I'm a voice of one, obviously, on this topic, but so I just think in this question, if it's about national innovation leader, we can't do it alone. We're going to need tech partners who are also themselves national leaders and global leaders. And as admirable as it all is, I don't think we're necessarily going to home grow, world-class technologies out of our organizations in Maine. We'll be able to home grow solutions, but we could probably go a lot further and create more impact if we were to partner in that endeavor with people whose job it is to build technological innovation.
Yeah, I couldn't agree more. I just keep thinking about the superhighway to that. If we were to build some infrastructure, something that would, grease the wheels, something that would be an enticement, it's probably not the demographics or the draws to some other areas that are really putting people in those places. So I guess the question is what stands out as a natural resource that we have that we could polish up, that would be a beacon to those folks.
I have two thoughts in the few minutes I have left, and I'll stop talking. One is, and I don't know if other states also have this too, but I know we have it. We have in Maine Health a comprehensive ecosystem that spans rural and urban communities, that has networks of providers in rural parts of the state that are maybe different than in urban parts of the state. And we also have the ability to see through to the patient data in all of those ecosystems. I would imagine all that data and its diversity and a unified organizational view and access to it might be appealing to a well-funded tech company who wants to sell, the next version of Epic to systems like Maine Health around the world. And offering to be a design partner in that way to such a group might be enough of a carrot or a draw. In the context of the conversation we had the other day around energy, again, I don't know anything about energy, but I do know we have a climate plan in the state, and we're really focused as a people around sustainability. And so, the carrot for something like an energy focused solution along these lines, I know this is about healthcare, but just as an example, might be renewable energy, water and wind as a way to differentiate. I think Dan even said such a thing, that all of these tech companies and energy companies have their own sort of clean energy goals. Maybe Maine can compete by standing out because we have some unique advantages with respect to wind and water, as opposed to however else energy is created in New Mexico, or wherever it is.
I was just thinking too, Chris, that I think because of who we are and technology, doesn't always look at specific sectors. So we're talking about healthcare here today, but we should be looking across sectors because AI is impacting everywhere, everything. Would that, if we took a more global approach to it to try to attract some of those innovators, would they be more interested in something like, we're not just talking about healthcare here? Because I think that's where we get a little pinned down in healthcare, is that we leverage resources that have been specifically developed for healthcare, but sometimes we miss opportunities for cost savings and taking a cross sector approach, I think, might be effective.
That's a really great point, right? You know, invest in these one or two areas, and then as phase two will help you in other parts of your roadmap as a tech company.
I'll put in a plug for a conversation that's happening in the sort of economy subgroup around a very similar kind of idea around, we as a state have specific policy goals, and Chris, I think you laid out the climate and energy goals, and sort of I'll add like infrastructure resilience and sort of storm resiliency in there as well. If we have those goals and we're already working on collecting data and increasing our data capabilities, is there a direct connection to be made to, we're building out a bunch of sort of data capabilities and we want to draw in new business activity that relies heavily on sort of access to good, clean, open data that's regularly updated? Is there how do we continue to draw lines of that will attract new entrepreneurial activity by sort of laying the groundwork, by providing the ingredients for building sort of AI models? And I think, we were sort of talking about it from the resilience and infrastructure and climate side, but I think you can make a really strong argument that it cuts across different sectors, which, to your point, Daniel.
Yeah, and in our workforce subgroup, we've been talking a little bit about just the state itself, right? Look at what state government does. It serves all of us in so many varied and different ways. Just being, if you're, pick your favorite, tech company, and you want to work on all the problems that state agencies are working on in order to develop multiple products and services that you could bring to market, being open for business and asking for investment and partnership could also dramatically improve and ease the operational strain on all of our state workers, as an example. I know this is the healthcare group, but.
So from a healthcare perspective, you said that the Maine health system is a broad system with a unified ecosystem in terms of healthcare records. Could Maine lead the way? The entire state could have a system that could talk to each other?
Well, I think it depends on what you're talking about, right? I mean, I think when Chris said that, I think you're maybe meaning it has the Epic EMR and their providers are all connected to it. Others use Epic, but it's not all one system. We also have Health InfoNet, right? That is one system that anybody could talk to, is maybe not as utilized as it could be. So I'm not sure if you mean that. I was also just going to put, before you go, Chris, I was going to put a suggestion for a modest editorial change. If to the extent that this conversation gets captured and shared with others, I think we're better off saying Maine has several health systems or networks of providers that for us to come out and specifically recommend something for Maine Health is just like asking for.
I think I'm glad you said that. I didn't actually mean anything too specific. I meant whether it's Maine Health or any of the other statewide systems,
right.
We have such a diversity of people and ages and urban and rural. And I mean, there's so many dimensions that we could bring in and overlay against the weather data, the economic disparity and differences throughout the state. I would imagine in an age when data is the gold and everything, that variation that exists in Maine is what I was really trying to describe. But I totally agree with you on the point you just made, Lisa. I wasn't advocating for Maine Health per se.
Yeah. But say more, Mary, on what you mean by.
Well, when I think about enticing, and again, coming from a place where there's, 17 hospitals and, the same 4 square miles, all with different instances of Epic and or many other things that are either, too forward thinking or too behind thinking to really be engaged in terms of patient records. I think that it might be enticing to be able to do something that allows some level of uniformity for AI companies to come in and be able to provide that same level of care, whether you're a private clinic, off somewhere else, or whether you're part of the Maine health system, or whether, that all Mainers have this connectivity to AI through the EMR. I don't know that it means you have to have the same instance of Epic, but there has to be some common feature made available and built into the communication of records that could all be leveraged, like a common outlet that could all be plugged into to be able to use systems. And that would be, I think, unique amongst other states in the union to have that common commitment to healthcare in that kind of patient record forward way. So again, not sure exactly what that means, and I'd have to talk to some of my friends in the EMR communities to catch up on the latest and greatest. But to really offer that kind of, if you built it this way and it looked like this plug, it would fit this outlet, and you'd be able to get everybody in the state.
Agree. It would be great. How possible that is, I don't know. Although I do think of Health InfoNet again, but I don't know.
Lisa, I wonder if it's worth spending 2 seconds talking about the very see you, Chris, the very early stage
Thanks, Chris.
idea around what like a long-term sort of governance structure might look like from the health perspective. We were exchanging emails with Scott earlier today and yesterday. I don't know if that idea is worth taking out for a walk, but it sounds to me a little bit like a version of the conversations we were having last summer, where we tried to bring a bunch of the different health centers to the table to talk about common issues and common opportunities, may sort of get part of the way towards what Mary's describing. And I don't know if you wanted to either describe what happened last summer or the conversation around sort of a working group that might last in a little longer than this task force.
Yeah, no, I think it's a good point and relevant. So Dan, Scott Kleiman was asking earlier today, is healthcare sort of special enough? So this is the last scheduled meeting of this group. Governor's task force is scheduled to go through the fall, but is healthcare, special enough that we ought to think about some mechanism, group, structure to continue these conversations across stakeholders in Maine related to AI and healthcare? And I certainly would vote yes on that question.
I think so, because we're talking about like the potential risk to human beings, I think is higher with this particular use case. And there's a ton of opportunity here too. So with both of those things, I would vote yes.
Yeah.
And I would add to that the challenges being faced by, rural healthcare communities, particularly in light of budget cuts and other things, just make it more of a rally cry to find things that are going to really serve the needs of the patients.
Right. And Lisa, CCPM has an AI governance committee for their ACO, right? So could we build something larger that was more inclusive for everybody across the state and start to establish some of the guardrails and some of the tools that people might not have? Like, I'm just thinking about CQI. Anytime that we're implementing something new, we should have a CQI plan to make sure we're capturing things quickly if there are risks or opportunities for improvement. Like, we could build some of those tools and make them accessible to everybody instead of like, okay, they're available to the people that have the most, so that we're not contributing to inequities. We do this with telehealth. Like, inequities can be exacerbated if you don't do it right. And I think AI is the same. So could we develop like a governance committee, like Dan is saying, or something else that we think is, implementation committee or, something like that, that could really help people leverage tools without having to recreate the wheel.
Right. The word governance, I'm guessing, might scare people off.
Yeah,
but,
maybe that's why I said maybe an implementation, because we don't want to make it seem like it's Big
we're
Brother.
Yeah. Yeah, no, I think it's a great idea. And Dan Matz's reference to last summer was really just this getting started, actually, with Dan Carteret, highly involved. We convened sort of key stakeholders from across different provider groups just to have a couple of conversations about what's happening out there it was before the governor actually even, well before she announced the formation of the task force. And there certainly, it was not hard to get people at those meetings. There was certainly a lot of interest, and I'm guessing it'd be even more so now. So I think absolutely that is something that both could be helpful and really would be necessary to trying to accelerate the adoption, implementation of AI in ways, particularly the connecting the large with the small, or the haves with the have-nots, as I'm apt to say, but shouldn't say out loud. yeah, I think that'd be a great idea. I think, the question I had asked back to Scott in the email, Dan, was, what's the best structure for that? Is that a state structure like this that, continues? I mentioned Danielle, certainly through Northeast Telehealth Resource Center we have a telehealth telemonitoring advisory committee that's supported through a state contract, actually DHHS 2 Netric, probably not nearly enough, but Danielle's been very gracious to keep that going with modest state support. And could that be expanded or, widened to incorporate AI, probably a separate or parallel group or subgroup or something like that related to AI, since that is something that exists, people recognize, we have representation from the major health systems and many of the other provider groups there, but something more explicitly built out within that structure might be another option.
And I mean, thinking about some of what we heard on Wednesday around the bills that came up in the legislature here in the state this year, and the sort of multiple bills around benefits negotiations and insurance issues, and how do we, sort of help people navigate those tricky healthcare related pieces as AI becomes more it proliferates more and more. I think it just continues to be as you say, a special set of problems that are common across a lot of these conversations, but are really heightened. And I think, Danielle, to your point, because people's lives are really, at the stakes here. So it's an interesting idea.
I wonder if that exists in any other state. I've not heard that yet. I don't know, through your Netric circles, Danielle?
Yeah, not that I'm aware of. It's not to say that people aren't thinking about it, because I do think they are. And I certainly can reach out to the other telehealth resource centers to see what's bubbling up in their specific. There's definitely been states that have sort of established themselves as leaders and are moving very quickly, Colorado and some others. But yeah, it'd be really interesting to see what others are thinking of and what's been particularly successful. I did have a great follow-up conversation with from Duke.
Mark Sendak.
Mark Sendak. I always want to say Sedlak, Lisa.
Oh no, don't do that to me. No.
Sendak, yes.
Just think where the wild things are. Maurice Sendak, there you go. Who's not related to Karen.
Yes. So anyway, and just thoughts that they've had or things that they're looking to achieve through some of their work to basically take what they've done internally at Duke and spread it and replicate it and make positive impacts elsewhere. So yeah, I think there's lots of folks that we could be talking with and learning from, and also setting the pace as a state as well.
Yeah. So that might be part of consideration under Q3 in terms of being a national leader, right? That could fit under there. Other thoughts about either Q2 or Q3?
Is there a way that the state could incentivize the use of wearables or data health collection that would, again, be an enticement for industry to come in with a large collection of data somewhere, and then also really enhance the rural telemedicine concept by being able to really follow people's health from an everyday perspective at a distance? And is there a way to kind of make those wearables more available? Like, I'm wearing my Aura ring right now. I mean, like, it would be great if I got a tax rebate for that or whatever it is. And that, by, having patients, be able to be followed or submit some of that information, they would be able to look at Maine health trends in a way that would be helpful, and hopefully not pernicious, but helpful.
So I'm intrigued by that. I immediately react a little bit with I think there's a little bit of a political issue with that right now with
Yeah, sure. But at the same time, when you look at countries like, Finland, or, they're really thinking about elder care, and they use these, what seem like microscopic changes in daily activities, mobility, body temperature, many of these things, to start saying, looks like you're coming down with something. There's something that's really affecting your recovery, your restfulness. Like, that's something that you should get addressed. Or, you didn't, those those pathways. You're not taking the same path to your daily chores that you normally do, and they start to bring up these things that really help people to have intervention at time before it's, more critical. And then they get more angry because they can't see a physician, because now it's gotten to a point where they really, or they go to see a physician, but they don't really believe them because they don't have the data behind it to show that what they're feeling is represented in some of the diagnostics, right? So I think, there are countries that are really embracing this. I know that we have our issues with it. And of course, any number of bad things could go wrong, but could we set a standard for healthy living, particularly amongst the one thing that Maine has is a broader, older community, right? Who want to be, sort of emphatically want to be independent, is there a way to help manage those communities more effectively?
Mhm. Even before the introduction of AI into telehealth solutions like RPM, which is very common now, and there's a lot of specialty RPM popping up for lots of different types of populations. I think the biggest fight or concern we've heard is like, holy hell, what am I going to do with all that data? And am I liable if I miss something with this massive amounts of data coming in? So I think we could actually leverage AI to be smart and help triage. And we've been doing this, right, to triage like CHF patients. This patient, it's a small enough anomaly so that it's not emergent, but this one is. And so we're going to triage the nursing resources there, or like, and having a son with type 1 diabetes and having constant access to his data, which he loves, by the way, as a 23-year-old person. My husband goes nuts about it and freaks out on every little thing. And I've learned, because I know, we've got to balance this, but can we leverage AI to not overreact to certain things, but also to respond, Mary, like you're saying, to help be more proactive and preventative, and also obviously for acute issues to get resources into the places that we need them when we need, to the people that need them the most in the moment. But yeah, it's a big can of worms, I think, because there is a lot of data to manage.
This was also a huge concern in the genomics community when people started to do whole genome sequencing, that there would be all of this data and who would be responsible for the action of, the actions taken based on it. And, big concerns about everything from paternity, like you could tell a lot of things from somebody from their genome. So big concerns, like, do you sequence for one thing and find a BRCA1? What do you do? Do you tell them, like, this really has been dealt with in so many other ways before, that I feel like there are some best practices out there to lean on in terms of what you do with all that data and the parsability of it and the usability of it. But I agree, but what an opportunity. I mean, that's the thing. AI, I keep hearing from AI experts about how there isn't enough data, and that the more data, they need more data to do more things. And, if we could figure out a way that Maine could become that incubator for something that, again, brings real value success stories to people for things they care about, that not just floods them with more ads, not just not just ends up being like a consumer play or whatever, but really brings them help that they need. That I think could be very valuable.
I think we had talked in our last call about an idea around remote patient monitoring around like cardiac patients, or sort of going to philanthropy and picking a specific thing and saying, what do you think about building out sort of a version of Mary of what you're talking about there? And I wrote that down under sort of the big swings section, and I wonder if that's again, we sort of skipped over this at the beginning, but my short spiel around where we are in the process here and trying to get to something resembling sort of real, a real set of recommendations for the task force to consider, as we get into later in the summer and early in the fall. And I really think it's a very intuitive thing to understand that, as you say, Mary, hits really close to home and provides really demonstrable, could provide demonstrable positive impact on a lot of vulnerable people's lives. So I'm just drawing that line between what we talked about, I think, in our last call and this.
And maybe under that section of right now you've got a second bullet under Q3, maybe it's several examples, right? So you've got the remote patient monitoring for cardiovascular patients. Another might be, as Mary is saying, use of wearables in older adults for remote tracking to monitor for occult conditions or, whatever, when they need help. Another on the AI pilot idea that we had talked about before. So those two are both geared towards patient monitoring or remote patient monitoring. Another that we had talked about earlier on, I think, was back to ambient documentation. And could we ever find philanthropy money to plug the holes where that's not happening right now? So it's certainly taken off like wildfire, at Maine Health and probably some of the other larger ones. But I'm certain there are still large swaths where it's not happening. And it's those with less resources and less of an IT infrastructure. So I think the idea was, could we do something and organize statewide adoption of one or more tools for ambient documentation that really help address some of the workforce issues.
And Sparwing just got the Davis Family Foundation
Right.
funding specifically
Right.
to integrate. Yeah. So
Right. So it could even be in both physical health and behavioral health side.
And you're starting to see, I think, a few more of these funding opportunities popping up as people start, as money starts sort of coming to terms with the opportunity here. I saw something earlier today with a new fund around specifically like government and recent federal policy changes and safety net programs and things. So it's definitely a hot topic, I think, for the funding community. So if
really
we
love the public-private partnership opportunity too, like a large employer. Think about that in the state of Maine. And could we leverage AI for specific healthcare conditions that are really impacting the productivity of their workforce, for example, or safety, or like the healthcare linkage to, and that goes the cross-sector thing too, right? Like our economic development and our ability to remain productive and have, folks showing up to work and feeling good every day. So.
What else? Maybe that under the first bullet there, under Q3, I think, Danielle, to your reference a few minutes ago about Mark Sendak, the notion of a statewide system of education and support to help providers adopt AI. That's a concrete thing.
Yeah, and he mentioned the idea to me that they would love to, for example, serve as a national TA hub, but they don't want to do all the stuff. They want to work with states like Maine to put resources into, our state as a statewide. So it's almost like a hub and spoke model of a TA hub, if you will, so that we're developing things maybe in collaboration with people like him and others. So we're not recreating wheels, but we're also developing solutions that are unique to the needs of people here in Maine and the health systems and the patients and everything. Yeah.
Mm-hmm. So the two key ideas there under Q3 are a system to support innovation, implementation, learning, in a continued way. And the second is specific AI pilots that we just talked about a minute ago of potential different types.
And Lisa,
first, potentially being able to support the second.
Just to the point of this current conversation around upskilling and training and exposure to tools and things, I wonder, drawing a connection between that and a couple of the bullet points under question 2 around safe and appropriate usage in healthcare. I think we had said sort of train the trainers, get people trained up, get people exposed, get people literate. And I don't know, Danielle, if that sounds like the kind of work that Mark is sort of advocating for, but I'm curious how the state, where the state can show up in folks' minds in terms of getting people on the ground in hospitals, in urban settings, in rural settings, all over, to what role does the state play in making those people sort of more comfortable and more knowledgeable about artificial intelligence and the responsible use of artificial intelligence? I don't know if that is the framework that Mark was describing. They come up with training ideas, they give it to the state, and the state distributes it. Is that a way of?
I think that, and because they're a big shop and they've had some specific funding, for example, to do research and implementation pilots with FQHCs, for example. So it's more sharing sort of the literature that's being developed, that we might not necessarily, each individual state or individual organizations might not have the capacity to do that, but to share those kind of evidence-based or promising practices resources out of the hub that has a lot of resources. And then we can adapt them to fit the needs of our unique states and organizations that we're working with. I think that was kind of his thought process. Yeah. And honestly, we would contribute back to the mega hub, if you will. Like, I think we would have lots of great stuff that we could develop and share back with them. And then they could distribute that to other rural states that are trying to learn and implement and leverage it to the best and safest capacity. Yeah.
A helpful way to tie protections needed to ensure safe and appropriate usage also to emerging as a national leader, and sort of having those two sort of tied up neatly with a bow with an idea like that. So
yeah. Other thoughts about any of the three questions?
Lisa, can I ask you a question from the DHHS perspective, if we have the time to do so? I'm interested in hearing about it from like a state health department, how you all are thinking about taking advantage of tools sort of internally, if that conversation's happened at all. Obviously, such an important part of the ecosystem is the sort of state HHS departments, and if there's a place for us to recommend or think about ways for those kinds of bodies, or that kind of body in our state to act as a first mover on some of these things.
Yeah, it's a great question. I don't know that we have answers yet. So I have, as part of my role on this group and the task force, I have brought it up several times, within commissioner's office discussions and the office director's discussions, and really urge people to think about what could even one or two, use cases that pop up to them. So I've asked people. We haven't really had answers yet, but sort of challenged them to think about something, and that we would be coming back. I know that one of our office directors for OFI just recently was at a national meeting where they were talking about this, and Commissioner and I actually have a meeting, so that's Ian, to talk with Ian actually next week, because she has been charged with getting some of these ideas back about specifically how you can use it within DHHS. So I think, OFI and Maine Care are two pretty obvious spots. Also, actually, just even what's the office that takes consumer, complaints, or what do you call it when you interact with consumers who are calling, and trying to summarize those and identify themes. So there's been several ideas that have come up, but so I think work is going on to try to identify those more specifically, and hopefully we'll have something for you soon, but I don't have it right now.
It kind of makes me think about, I don't know if folks saw, it was pretty, I think it was yesterday, on the national news. They talked about how this couple, massive frustration with continuous denials on a claim, and they actually used AI to create an appeal to their denial of their claims.
Bot wars. It's the war of the bots. Yeah, they're just going back and forth.
Yeah. And they actually, after multiple times, that final AI version was what actually got them to reverse the denial of the claim, and it's paid. But so just thinking from a Maine Care perspective, and the number of like maybe incorrect claims, like it would save a lot of time if claims were coming in correctly every single time, right? And you think about a private payer perspective on that too. And I think we've talked about having payers around the table moving forward on some of this to get their input as well. But anyway, yeah, I think there's a ton of opportunity there.
Yeah, and I certainly, Lisa, that was not meant to like sort of put DHHS on blast at all. It was sort of just thinking about the folks, and Danielle, to your point, thinking about the other people who are players in the sort of healthcare space here, and one conversation that I know is happening a little bit in the sort of risks and legal sort of group on is thinking about as agentic AI really becomes more publicly available and people can put agents out into the world. I mean, they're already, we heard from someone in the Bay Area recently where if you want to get a reservation at a fancy restaurant in San Francisco, you have your agent just call nonstop to every restaurant that fits your, your criteria until you get one that matches your needs and your timing and your group size. That's like sort of a flip example, but you can imagine calling to hear about the status of an approval or having just the sheer volume of interactions really just multiply because of the sort of ease of deploying these things and making sure that sort of state and municipal and other systems are as prepared as they can be for what might be coming out of that. This is the scary conversation here, unfortunately. But
yeah. All right.
At some
What
point, you have
else?
to be able to live unless you have an AI advantage. Like
Yeah.
able to get through traffic lights if you don't have a tool. I think, I don't know. It makes you wonder.
And the data systems, the grid needs to support them all.
Yeah.
All right. Other thoughts? Any of the questions or other considerations? Dan Carteret, you're being quiet and you're listening, but you've been deep into this. You must have other thoughts percolating around your head.
There's definitely one thing I was thinking about earlier. This is going back pretty much to I think the first question that was raised during the meeting, and I think I can't remember who raised both points, but I think someone raised the issue of sort of the messaging to patients, and someone else raised the issue of like messaging to workers with respect to adoption of these new technologies, and sort of the need to think of it as like complementary and not replacing people. And I think that is like, I think the heart of that is certainly true, but I think one of the things that, I mean, I definitely spent a lot of time thinking about over the past year is just the fact that in both the sort of the patient, sort of the general population of the state, and then also in the healthcare workforce, there is sort of like this demographic trajectory where people, the number of people fulfilling these roles is going to be smaller than it used to be, and that people have been accustomed to is very likely to happen unless sort of something outside of all of this AI conversation dramatically shifts. So I think both for like patients and then also for people in these spaces, I think that the sort of the groundwork needs to be laid like a little bit differently, and that I think what people are going to be sort of naturally comparing whatever the next evolution of healthcare is going to be what they've been used to in the past, right? And so they're going to see maybe there are fewer. It's harder to get in touch with a doctor or caretaker than it used to be because there's more demand and there are fewer people fulfilling those roles. But I think but I think there's also I think a useful comparison thinking like what there would be without thoughtful adoption of new technologies. And so I guess it's just there's sort of the way I think from people who are sort of thinking about this from a policy perspective, that second comparison is like incredibly important to think about like what the alternative is without embracing some new technologies. But I think that's not necessarily what other people are going to be seeing who are not immersed in this thought process on a regular basis. So I think figuring out how to bridge that gap is going to be a real challenge, but something that should probably be tackled sooner rather than later. So that's sort of one big picture thing I was thinking about.
Mhm.
Communications.
Yeah. Great, thank you. All right.
I'm guessing the risks committee, subcommittee, or work group is thinking a lot more about this stuff, but I think that some of the risks obviously are unique in healthcare and are maybe a little more like just of higher, more acute concern. But should we be looking at and have a plan for each of the kind of commonly identified risks and concerns, so we know the bias, the accuracy, like all the things that have been identified by pretty much everybody, AMA and whoever, and developing an explicit plan to proactively address those. I'm not trying to overprescribe, but I don't know. It seems like we might, especially with it when it comes to communications, and we find this with telehealth, real or perceived. People are nervous about using it for specific reasons, but then when we are able to educate them and make them more comfortable with it, maybe then that concern goes away. And so just thinking about getting more explicit about those identified risks in the healthcare space.
One concrete idea that you could consider that I don't think made its way into what I wrote and shared with you, Lisa, but maybe should have, was and Dan, I can't remember, we might have actually talked about this more generally for AI in the state last summer. But just as sort of a sort of catch-all precaution is to have some sort of reporting system similar to, I can't, Lisa, maybe you can help me out. I'm blanking on what the system is for like the FDA for like adverse events.
Oh,
For
yeah, it has a name. Yeah.
right, and you get a lot of noise with that. You get a lot of
Mhm.
right. You get a lot, anytime anyone gets a headache after having taken like the new the new COVID vaccine or something like that, it goes in
Mhm.
there, and it might be they might they might be dehydrated. Who knows what's going
Mhm.
on? But I think some sort of I think that's also again both like a substantive, a potential. I mean, if it was done, it would probably have to be done very carefully. But this is something that can be both potentially substantively helpful for early detection of real risks, but also be useful for messaging, and that sort of you have you're you are providing an avenue for people to voice concerns and to have them be addressed. But yeah, I think thinking about what to do on the back end with any information that gets captured there, but some sort of like adverse event reporting system for suspected instances of bias, suspected instances of mistaken recommendations or hallucinations or whatever you want to call them.
Yeah, it's almost though,
Yeah.
and so I think it's a good concept. I think in this particular instance, it's almost that it would have to be within the provider organization, though, to start that versus a centralized, right? Because if it's centralized, how are you, or maybe it's a two-tier thing, but it seems like starting the process
Yeah.
close to home is.
I mean, is it something that could the state could conceivably require providers to do, and then it gets
Escalated if
aggregated
it's.
up at the
That's what I
state
was
level? Yeah.
wondering on number 2, like, do we need to set some policy guardrails that would set specific recommendations? Hey, if you're going to use this, we need you to internally capture and continuously analyze, negative impacts. Or, I mean, to me, I'd also want to collect positive ones too. And that way you've got a great data set. It contributes to the transparency that we talked about, which is really important. Even if it's only internal to that organization, but they have that structure to capture it and to adapt and quickly address the issues. Yeah, I think that would be really cool and important.
Yeah, and I mean, boy, it seems like it could go a long way in building trust if both patients and providers knew they had some way to quickly report a concern and have it be addressed, right? It's potentially a very big system that we're talking about, but I love the idea.
I'll just slightly going back a couple of minutes, just Danielle, to your question earlier about the risks group sort of wrestling with some of those ideas. I think the short answer is yes, and the slightly longer answer is there's a lot of conversation around how to engage with as many people as possible to raise the sort of baseline level of understanding and literacy here. And I think largely with sort of two goals. Number one is to say, look at the ways that this might be able to help you in your work in your life. And number two is to say, if someone's trying to take advantage of you using these tools, if you are experiencing harm in some way, you'll be better equipped to recognize it early in theory and go about the possible ways of mediating it, including, bringing in, reporting or filing in some way. So that's a slightly long-winded way of saying I think that's a really specific solution that I think we're circling around, or that group is circling around, I should say, and it would not surprise me if a version of that ended up as a key recommendation. Although I don't want to get too far ahead of Mary and everybody else here.
I don't feel like you're getting ahead at all. I think it's a great comment.
Is there a readily accessible list of, big category risks from that group? To Danielle's point, Dan, if we could look at each one of those as they apply to healthcare and some recommendations for how to address or mitigate.
It's a great question. They are in the middle of doing an analysis of, I think the number is up to 10 sort of baseline risks. So things like bias and sort of specific other, election issues and deepfakes and things like that. I am not sure what state it's in. I would be happy to follow up with that group and see if they can, if they feel comfortable sharing, or if they're still sort of in the nascent stages. Although as we get further into July, hopefully that those nascent stages continue to advance here. But I do know that they are planning on addressing specific sort of health issues. I do think largely it's around legislative and regulatory gaps, and trying to analyze if there's a place where our current legal and regulatory system doesn't protect people adequately from new or exacerbated harms out of AI. So let me circle back with Justin and with Scott and see what this status is on that work. But
that'd be great. Yep. So I certainly want to keep it open to other thoughts, input from the group. And I'm curious, Dan, in terms of process and, writing up some recommendations from this group to the big group, how do you see things evolving next?
Yeah. Happy to circle back to what we sort of kicked on the road here. As we know, it is somehow already the 18th of July, which is scary and unbelievable, frankly. But we are, the task force is charged with delivering recommendations, as we know, by the end of October, in order to make sure that those are, completely well written and, fully written and fleshed out and designed and packaged nicely. We are looking for this group to return a set of sort of draft answers to the questions that we've been spending our last 60 or so minutes going over here by the end of this month. So I will just say what we're looking for is sort of from a deliverable, just to make sort of hammer the point home, is a document that has, it could be bullet points, but some sort of fleshed out answers to the questions that we've been that we've spent the last couple of months talking about. by the end of this month. I believe we're still sort of fleshing out what the fall is going to look like, but largely I think when the task force reconvenes in September, it's going to be about digesting what all 6 of the groups have put out, have brought back to us, and collating and synthesizing all into one place. Mary, I don't know if there's anything else you wanted to add about what this group sort of is charged with producing here, but.
Well, I think it's, I think you have it about right. I think, again, I haven't been keeping tight pace with what others are doing to sort of offer like you have, Dan. So I think really bringing it into parallel with what the others are preparing is really the key. So we welcome that framework here. But I think, overall, it's really a question of what we could put, like I said, like Chris mentioned earlier, we don't want to overstep and go into solutionizing, but really pushing for those things that, can, in all the categories, can help keep us on pace with a well thought out way to continue to adopt and be, leaders. And it's really crazy to think about Maine being a leader in this, but there is some special set of circumstances here that really work for this. We just really need to put them together and offer the right solutions so that we can focus in on that at the government, at the state level, and really figure out how the state government can really help those things to excel. So I feel like we're on the right track. And if there's anything we're missing from the parallelization, Dan, please let us know.
Yeah, I mean, the only other thing I'll say in terms of takeaways from some of the other groups, I mean, I've mentioned a couple of things over, this meeting, but I would say really, really solidly in line with a lot of the takeaways around transparency, around training, around literacy, around upskilling. These, I mean, every person who wrestles with these, no matter what sort of their industry is going to have similar conversations. So definitely, right smack in line there. I think I think part of sort of our role as staff is to in some ways take the 6 different documents and make them all play nice with each other and sort of end up with something that is unified in form and in scope around the different industries and sectors and topic areas. So I think this group is sort of right in line with a lot of the other conversations. I think there's going to be a conversation with the broader task force around sort of how to sort things into priorities and how to figure out what's the thing we want to recommend doing first and what's the thing that maybe is a big swing that we build towards. But I think that's a conversation for the fall. I think for now, getting everything down on paper in a sort of a unified way is really what we're looking for. And again, feel like we're right running up to that. So
yeah, I guess maybe the only thing I would add is that in any cases where we could offer examples, like when we talk about the transparency issue, if we could say akin to the patient's bill of rights or the patient's, financial projection or whatever it is that we could offer as a sort of, example of what we're trying to get out there, I think would really be helpful. And then I think the last thing is there are certain industries like healthcare and banking and where there's, privacy issues that sort of supersede some of the rest of the, what your purchases are at Hannaford are different than your healthcare profile, right? So that we have to make sure that we have that stuff covered.
I really hate that they know when I buy ice cream and cookies.
I really hate that it pops up on the feed so that, my
I
family
buy more
knows when
ice
I
cream.
buy ice cream and cookies because it's harder and harder to hide it. Like I don't get any.
Oh boy. Okay, all great suggestions. Just going back to the process. So Dan, you've been very good at capturing these notes and in the meeting today. I think, any of us would be happy to help with that as well, but clearly you've got a great start at it, so I don't want to recreate anything. Are you envisioning sending a draft to this work group ahead of the end of the month, or how are you seeing that process going?
I mean, I'm open to different processes here. I think I would like, if it as a sort of we're coming at this from a staff perspective. I would definitely like your pens to be more reflective of the sort of final draft, just making sure that I'm not taking too many liberties here, again, as someone from the staff. So what I'll do is I think what you sent, in this agenda is we've added some nuance and some sort of new ideas and a couple of new examples to Mary's point, but I think it gets us a lot of the way there. And so I'll spend some time over the next few days pulling that into just an updated version, I think, Lisa, of what you sent out, and get it back to you, and then sort of cycle through the rest of the group before the end of the month to make edits and updates. But I think, again, largely want to make sure that you all, the experts in the room here, are sort of leading the charge on the content, and making sure that you all get a chance to look at it. So does that make sense? So over the next couple of days, we'll get it back to you all.
Okay. And then just to keep, for us to recognize, it's a relatively short timeline, because you're due to get something back to somebody else by the end of July, which is really 2 weeks from right now.
It's really, you're due to get it back to me by the end of July, I think, is really what it is. So we're the people. So Scott and myself as staff are going to take it, spend much of the month of August digesting and synthesizing, with input from Mary and Dave, and making sure that, by the time we come back in the fall, we've got something for everyone to react to.
The group to see. Yeah. Okay.
So,
okay.
Yeah, I'm sort of at the end of the day, it's going to end up on my desk, and I'm going to spend a lot of the beautiful month of August hammering away at and making something out of it. So.
Okay. So we'll wait for an updated version from you, get it around. We could either do the small group that was on the call today, or just the whole group at once. Yeah, I'll think about that, what might work best, but then everybody gets a chance to get thoughts back to you by the end of July.
Yeah, that's great.
Okay. All right. Well, I think that was a great discussion. And unless there's anything else, we're probably good.
And it has nothing to do with healthcare. But since you just said you're going to be, and you may have already seen it, but Texas DOT actually has a strategic plan for 25 through 27. I like to look at templates of what other people are doing and how they're thinking about this stuff. So I just popped it in the chat in case it's helpful. And I mean, you're looking at this across different sectors. So in case
it's about AI though.
Yeah. Yep. It's their AI strategic plan for the state of Texas DOT.
I
to read that, having been a Texas taxpayer for 19 years, I can tell you the roads, don't let the roads flood. That might be one of the major things that they have in there. I have some connections to the DOT in Texas, and actually one of the main connections I have is a former VP level person, and he is married also to a healthcare clinical trials VP for research kind of person. So I think we could get some translation if we need it. If the drawl is too heavy for us to understand, we could probably put some color around that if we need to.
Fantastic. I appreciate that. I'm adding to a list of a bunch of different states who have done this kind of work, and I will be very blunt that we are happy to crib wherever we possibly can. And not reinvent the wheel here.
Work smarter, not harder.
Yeah.
Absolutely.
That's great.
It's the AI tagline, really.
Yeah.
Yeah.
I'm about to create an AI summary of the document as well, because that seems to be an option in Adobe. So it's perfect.
Awesome.
Wonderful. All right.
Awesome. Okay. Well, thank you guys. Dan, anything else from your end?
No, all great. Good to see everyone, and yeah, looking forward to digging in.
Awesome. Okay. Thanks, everybody.
Have a nice weekend,
Thank you.
everybody.
Bye, everyone.